So what is edema? Edema is the accumulation of free fluid in the interstitial tissue space and serous cavities. The presence of abnormal collection of fluid within the cell is sometimes called intracellular edema, but should more appropriately be called hydropic degeneration. So under normal circumstance, tendency of vascular hydrostatic pressure to push water and salt out of capillaries into the interstitial space and nearly balanced by the tendency of plasma colloid osmotic pressure to pull water and salt back into the vessel. So it is the balance between vascular hydrostatic pressure and plasma osmotic pressure. What happening normally? It is the arteriolar end and this is the venular end. In arteriolar end, hydrostatic pressure is more and in venular end, it is less. But osmotic pressure or oncotic pressure is equal in all the sites, in arteriolar end and venular end. So when the function of hydrostatic pressure is to push water or fluid from the capillary to organ, and function of oncotic pressure is to pull the water from, but the osmotic pressure is equal in both the sides, arteriolar end and venular end. So when osmotic pressure, the function of osmotic pressure is to pull the water or fluid in the capillary. So when increased hydrostatic pressure will occur, so fluid will push from the arteriolar side. This is called interstitium and this is the tissue. So there is a small movement of fluid into the interstitium, but this drain into the lymphatic vessel and ultimately return to the bloodstream via thoracic duct, keeping the tissue dry. Free fluid in body cavities, commonly called as effusion. It is named according to the body cavity in which fluid accumulates. For example, ascites, if it is in peritoneal cavity, hydrothorax or pleural effusion, if in the pleural cavity, and hydropericardium or pericardial effusion, if in the pericardial cavity. Free fluid in the interstitial space. Commonly termed as edema, the fluid lies free in the interstitial space between the cell and can be displaced from one place to another. In the case of edema in the subcutaneous tissue, momentary pressure of finger produces a depression. It is called picking edema. Picking edema produces depression. And when it is solid edema, it is called non-picking edema in myxedema and in elephantiasis. Elevated hydrostatic pressure or diminished colloid osmotic pressure disrupt this balance and result in increased movement of fluid out of vessel. Edema fluid and effusion may be inflammatory or non-inflammatory. This protein-rich exudate accumulate due to increasing vascular permeability caused by inflammatory mediators. In contrast, non-inflammatory edema and effusion are protein-poor fluid that is called transudate. Non-inflammatory edema and effusion are common in many disorders including heart failure, liver failure, renal disease, and malnutrition. Now the causes of edema. Increased hydrostatic pressure. Increasing hydrostatic pressure are mainly caused by disorders that impair venous return. If the impairment is localized, that is happening in DVT, deep vein thrombosis, in a lower extremity, then the resulting edema is confined to the affected part. So DVT occurs in the lower part, lower extremity. And then reduced plasma osmotic pressure. These are the two important mechanisms causing edema: increased hydrostatic pressure and decreased plasma osmotic pressure. There are many other mechanisms, but these are the two main mechanisms. Under normal circumstances, albumin accounts for almost half of the total plasma protein. It follows that conditions leading to inadequate synthesis or increased loss of albumin from the circulation are common cause of reduced plasma oncotic pressure. Reduced albumin synthesis occur mainly in severe liver disease and protein malnutrition. So plasma osmotic pressure is occurred due to protein, and protein in our body, main protein in our body is albumin. So plasma osmotic pressure is mainly due to albumin. An important cause of albumin loss is the nephrotic syndrome, in which albumin leaks into the urine through abnormally permeable glomerular capillaries. So nephrotic syndrome is one of the causes. Regardless of cause, reduced plasma osmotic pressure leads in a stepwise fashion to edema, reduced intravascular volume, renal hypoperfusion, and secondary hyperaldosteronism. Then, third cause is sodium and water retention, increased salt retention. With obligate retention of associated water cause both increased hydrostatic pressure and diminished vascular colloid oncotic pressure. Salt retention occurs whenever renal function is compromised, such as in primary kidney disorder and in cardiovascular disorder that decrease renal perfusion. One of the most important causes of renal hypoperfusion is congestive heart failure, result in activation of renin-angiotensin-aldosterone axis or RAAS system. So what is renin-angiotensin-aldosterone axis? This is first key that decreased cardiac output. Due to decreased cardiac output, renal ischemia occur because kidney is getting less blood, so renal ischemia is occurring. Then GFR will decrease, glomerular filtration rate will decrease. Then renin will produce, and this renin releases renin in circulation. Then this renin will produce angiotensinogen in the liver, and this angiotensinogen will then produce from angiotensinogen. From angiotensinogen 1, it will produce angiotensin 2. And this angiotensin 2, which is produced here in the lungs, angiotensin 2 is the most potent naturally occurring vasoconstrictor substance, and its pressure action is mainly attributed to peripheral arteriolar vasoconstriction. The other main effect of angiotensin 2 is to stimulate the adrenal cortex to secrete aldosterone via AT1 receptor and thus promote reabsorption of sodium and water. So angiotensin 2 কি করে না mainly it promotes reabsorption of sodium and water. Then another mechanism is lymphatic obstruction. Trauma, fibrosis, invasive tumors, and infectious agents can all disrupt lymphatic vessel and impair the clearance of interstitial fluid, resulting in lymphedema in the affected part of the body. A dramatic example is seen in parasitic filariasis, in which the organism induces obstructive fibrosis of lymphatic channel and lymph nodes. This may result in edema of the external genitalia and lower limbs that is so massive to earn the appellation of elephantiasis. Morphology. Morphology, gross and microscopy. Edema is easily recognized grossly. Microscopically, it is appreciated as clearing and separation of the extracellular matrix or ECM and subtle cell swelling. Edema is most commonly seen in subcutaneous tissue, the lungs, and the brain. Subcutaneous edema can be diffuse or more conspicuous in regions with high hydrostatic pressure. Its distribution is often influenced by gravity, a feature termed dependent edema. Finger pressure over markedly edematous subcutaneous tissue displays the interstitial fluid and leaves a depression, a sign called peaking edema. Peaking edema always produces a depression. In non-peaking edema, there will be no depression. Edema resulting from renal dysfunction often appears initially in parts of the body containing loose connective tissue, such as the iliac periorbital edema, is thus a characteristic finding in severe renal disease. With pulmonary edema, the lungs are often 2 to 3 times their normal weight, and sessioning yields froggy, black-pink fluid, a mixture of air edema and extravascular blood cells. Brain edema can be localized or generalized depending on the nature and extent of the pathologic process or injury. The soul and brain exhibit narrowed sulcine and distended gyri, which are compressed by the unyielding skull. Effusions involving the pleural cavity, hydrothorax, pericardial cavity, it is called hydropericardium, or the peritoneal cavity, hydroperitoneum or ascites, are common in a wide range of clinical settings. Now the clinical features. Subcutaneous edema is important primarily because it signals potential underlying cardiac or renal disease. However, when significant, it can also impair wound healing and the clearance of infection. Pulmonary edema is a common clinical problem that is most frequently seen in the setting of left ventricular failure. If left ventricular failure occurs, then pulmonary edema will happen. It can also occur with renal failure, acute respiratory distress syndrome, and pulmonary inflammation or infection. Edema in the pulmonary interstitium and the alveolar spaces impedes gas exchange and also creates a favorable environment for bacterial infection. Brain edema is life-threatening if severe. Brain substance can herniate to the foramen magnum or the brainstem vascular supply can be compressed. Now, hyperemia and congestion. Hyperemia and congestion both stem from increased blood volumes within tissues but have different underlying mechanism and consequence. Hyperemia is an active process in which arteriolar dilatation leads to increased blood flow. So hyperemia means increased blood flow to a particular organ. It is increased blood flow. Affected tissue turn red, that is called erythema, because of increased delivery of oxygenated blood. But congestion is a passive process resulting from reduced venous outflow from a tissue or an organ. So hyperemia is in an organ, it is increased blood flow. Blood flow টা increase হচ্ছে, তাই জন্য হচ্ছে hyperemia. And congestion, it is the reduced venous outflow. Venous outflow is obstructed. That's why it is called congestion. It can be systemic, as in cardiac failure, or localized, as in isolated venous obstruction. Congested tissue have an abnormal blue-red color that stems from the accumulation of deoxygenated hemoglobin in the affected area. In long-standing chronic passive congestion, the associated chronic hypoxia may result in ischemic tissue injury and scarring. So you can see here heart failure. Heart failure is occurring. It may be two types: right-sided heart failure and left-sided heart failure. It is the consequence of left-sided heart failure, and these are the consequences of right-sided heart failure. So left-sided failure হলে কি হবে, the pressure transmit upstream from left heart, pulmonary congestion. So chronic venous congestion of lung will occur. Okay, this is the left heart failure. And it is the consequence of right-sided heart failure. So pressure transmitted upstream the right heart failure. Systemic venous congestion, so right side heart failure hole hobe systemic venous congestion. And left side heart failure hole hobe pulmonary congestion. So the consequence of systemic venous congestion are chronic venous congestion in liver, chronic venous congestion in spleen, then in kidney, then in leg veins. Okay? Because right-sided heart failure, right side is getting blood from right atrium, and right atrium, blood is coming from systemic organs, that's why. Now, the morphology. Morphology, gross morphology and microscopic morphology. Congested tissue take on a dusky reddish blue color due to red cells gases and the presence of deoxygenated hemoglobin. Microscopically acute pulmonary congestion is marked by engorged alveolar capillaries, alveolar septal edema, and focal intra-alveolar hemorrhage. In chronic pulmonary congestion, which is often caused by congestive heart failure, the septa are thickened and fibrotic, and the alveoli often contain numerous macrophages laden with hemosiderin derived from phagocytosed red cells. So this is the chronic venous congestion of lung. Here you can see thickened alveolar septa. These are the heart failure cell, intra-alveolar RBC. What is heart failure cell? It is alveolar macrophages containing hemosiderin pigment. Heart failure cell is seen in chronic venous congestion of lung, not in heart failure. In acute hepatic congestion, the central vein and sinusoids are distended. In chronic passive hepatic congestion, the centrilobular regions are grossly red-brown and slightly depressed because of cell death and are accentuated against the surrounding zone of uncongested cantilever that is called Nutmeg liver. These are the Nutmeg liver. The cut surface show mottled appearance, alternate pattern of dark and pale fatty changes. Now chronic venous congestion in spleen. Chronic venous congestion of the spleen occurs in right heart failure and in portal hypertension from cirrhosis of liver. Grossly, the spleen in early stage is slightly moderately enlarged, while in long-standing case, the progressive enlargement and may weigh up to 500 to 1000 grams. The organ is deeply congested, tense, and cyanotic. Now the microscopical features. Red pulp is enlarged due to congestion and marked sinusoidal dilatation, and there are areas of recent and old hemorrhages. There is hyperplasia of reticuloendothelial cells in the red pulp of the spleen that is called splenic macrophages. There is fibrous thickening of the capsule and of the trabeculae. Some of the hemorrhages overlying fibrous tissue get deposit hemosiderin pigment and calcium salt. These are called gamma-gandy bodies. This is the congested splenomegaly. The spleen is enlarged and heavy, and the surface is grey tan surface. Thickened capsule and congested sinusoid, and these are gamma-gandy bodies. Now hemorrhagic disorders. Disorders associated with abnormal bleeding inevitably stem from primary or secondary defect in vessel wall, platelet, or coagulation factor, all of which must function properly to ensure hemostasis. So these are the components of hemostasis: vessel wall, integrity of vessel wall, platelets, and coagulation factor. Defects of primary hemostasis. Platelet defects or Von Willebrand disease. So primary hemostasis is a defect when it is occur, defects in primary hemostasis, when platelet defects or Von Willebrand disease happen. Often present with small bleeds in skin or mucosal membrane. This bleed typically takes the form of petechiae. Petechiae means minute 1 to 2 mm hemorrhages or purpura. Purpura is slightly larger, that is more than 3 mm, and petechiae is small, it is 1 to 2 mm. So purpura is larger than petechiae. This is the pancreatic petechial hemorrhage in a colonic mucosa, a consequence of thrombocytopenia. These are petechial hemorrhages, small. Now, defects of secondary hemostasis. Secondary hemostasis, why it is happened? Due to defect in the coagulation factor defect. That is called secondary hemostasis. Defects in secondary hemostasis. Often present with bleed into the soft tissue or joints. Bleeding into the joint, that is called hemarthrosis, following minor trauma, is particularly characteristic of hemophilia. In hemophilia, hemarthrosis occurs. Generalized defect involving small vessel, often present with palpable purpura and ecchymosis. Ecchymosis, sometimes simply called bruise, are hemorrhages of 1 to 2 cm in size. In both purpura and ecchymosis, the volume of extravascular blood may be large enough to create a palpable mass known as hematoma. So hematoma is a large palpable mass of blood. Purpura and ecchymosis are particularly characteristic of systemic disorder that disrupt small blood vessels like vasculitis or that lead to blood vessel fragility. That happens in amyloidosis. Blood vessel fragility occurs. Hemorrhage can occur due to defects in primary hemostasis and defects in secondary hemostasis. Okay?